and it reduces LDL cholesterol without through a more indirect method. In a trial in renal patients, where they were concerned about using high doses of statin because renal patients are at increased risk of getting complications such as myopathy because of their renal function being poor. They only wanted to use a low dose of statins. They used 20 milligrams simvastatin, which produced only a relatively small reduction, in LDL, about a 30% reduction. But by adding ezetimibe, they were able to produce a much more substantial reduction in LDL cholesterol. So the combination allows you to get a big reduction in LDL cholesterol without pushing the dose of statin, particularly for patients who might be at risk of side effects. So here are the statin trials, statin versus control. Here are the more versus less trials that I showed you. 1 millimole reduction about 1/5, half a millimole a reduction of about 12%. What happens if we take not a statin but a combination of statin versus ezetimibe? Well, that lowers your LDL cholesterol by about 3/4 of a millimole, and it's producing a reduction in risk which is consistent with the reductions in risk produced by the same LDL reduction but by a statin alone. Now, that is compelling evidence that the ezetimibe is producing a beneficial effect on coronary disease as well as reducing LDL cholesterol, because this is also compatible with the reduction in risk being what you might have expected with the reduction in LDL produced by the statin alone. So it doesn't provide compelling evidence that ezetimibe is producing a reduction in risk through its effect on LDL cholesterol. And we're awaiting a trial that is looking at that particular question. They're comparing the addition of ezetimibe to a statin versus the addition of placebo to a statin. So that's a pure comparison of the benefits of adding ezetimibe. They're hoping to get a further reduction in LDL cholesterol, about 15 milligrams, and they're trying to pick up a relatively small, further proportional reduction in coronary disease. So, although ezetimibe is now quite widely used because it lowers LDL cholesterol, and because all of the evidence suggests that if you lower LDL cholesterol, you lower the risk of coronary artery disease, there isn't direct evidence that ezetimibe per se does lower coronary artery disease, and we're awaiting that evidence. The other issue that has come up is around whether it's just LDL or whether it's worthwhile intervening on other risk factors. So this is the observational epidemiology looking at the associations of cholesterol, different fractions of cholesterol, and risk. And because LDL cholesterol wasn't measured in these prospective observational studies, what they've done is they've used as a surrogate non-HDL cholesterol. So they just subtracted out from total cholesterol the measured value of HDL cholesterol. So this is a surrogate for LDL cholesterol, showing a very strong log linear association, as I showed you earlier, between non-HDL or LDL cholesterol and the risk of coronary artery disease. The HDL cholesterol is an inverse association. So the higher your HDL cholesterol, which is higher in women who have lower rates of coronary disease until menopause, increased by alcohol, increased by exercise, both of which are associated with lower rates of coronary artery disease. The higher your HDL cholesterol, the lower your risk of coronary artery disease. And the black squares are showing the impact or the lack of impact of adjusting for other potentially confounding risk factors. So for HDL cholesterol and non-HDL cholesterol, these appear to be independent associations. Whereas for triglycerides, when you adjust for other factors, the association goes away, suggesting it's not an independent causal risk factor. So on the basis of this, it looks as if one can get benefit not only from lowering LDL cholesterol, but also from increasing HDL cholesterol. So we were involved in a trial which will be published shortly of a very old drug for not only decreasing LDL cholesterol but also increasing HDL cholesterol called niacin. Niacin is a B vitamin. It's very widely used in the US in people who are considered to be statin intolerant or in people with complicated lipid biochemistry. It's not a very nice drug. It causes itching, flushing, gastrointestinal upset. But as I say, it's widely used in the US, rarely used in the UK or the rest of Europe. And what we wanted to know was, would it produce worthwhile benefit on top of simvastatin and ezetimibe? These were the lipid differences we produced, an increase in LDL cholesterol, about 1/4 mmol, a decrease in HDL cholesterol. And based on the observational epidemiology, we predicted that this should produce a proportional reduction in risk of about 10%, with about the same effect due to the LDL and to the HDL. And we had pretty good power, statistical power to detect that. However, what we observed over the 4 years of the trial was no significant difference between the people who got placebo and the people who got the niacin. There's a trend in favour. Instead of a relative risk of 0.9, which is what we predicted, it's 0.96. The confidence interval was consistent with 0.9, consistent with a 10% reduction, which is about all we would have anticipated. But there's no significant benefit. Bear in mind, this is a treatment very widely used, billion-dollar drug in the US alone. Now, why might we have not seen any benefit? Why might it be used so widely in the US? Well, there was a US study done back in the 1970s, before the statins were available. And one part of that study, which was people who'd had a myocardial infarction, so after a heart attack, they were given niacin, a high dose of niacin. And again, at that time, they never measured LDL cholesterol, they measured total cholesterol. And the total cholesterol reduction was about 0.7 of a millimole. Given that it's increasing HDL cholesterol, you can probably estimate that it lowers LDL cholesterol by about a millimole. And the reason why they got a big change in cholesterol is because they weren't giving it on top of a statin. So these were people who had high cholesterol levels and they were lowering it quite a bit. And they did see reductions in the risk of coronary heart disease and MI, and reductions in the risk of stroke. And these were significant reductions because they were having a big, or relatively big, change in cholesterol. But when we look on top of a statin, the change in lipids is much smaller, and therefore the potential benefit is much smaller, and turns out to be not detectable, even in a trial of 20,000, 25,000 patients. More importantly, though, we were able to demonstrate in this new trial that it produced big increases in serious adverse events. So these were things that got people into hospital. So it increased the number of diabetic patients whose diabetes went out of control and had to be hospitalized. It increased the number of people who had diabetes develop to a greater extent than what I showed you for statins. The gastrointestinal and musculoskeletal effects were known about before, but we found significant increases in infections and significant increases in serious bleeding. So in the current environment where we can give a statin and where statins are really well tolerated, do not cause side effects, this does not look like a good deal. There are newer classes of drugs coming along. I'm coming to the end. And that's been an exciting area as well. So these are a class of drugs called the CETP inhibitors. And there are genetic variants in the CETP, the cholesterol transfer protein, there are variants in that gene that affect cholesterol levels and are associated with risk, the differences in risk in coronary disease. They're compatible with the differences in cholesterol. So there looks to be a potentially causal association supported by the genetic evidence. And there have been a number of drugs in this class that have been developed recently that produce reductions in LDL cholesterol in most cases, not in the case of dalcetrapib, and very substantial increases in HDL cholesterol with torcetrapib, evacetrapib, and anacetrapib. So these looked really exciting. They were producing big changes in lipids, and these changes were seen on top of a statin. So the first trial that was done was in 15,000 patients with heart disease. They produced, on top of a statin, quite a big change both in LDL and HDL. These are much bigger than we saw with niacin on top of a statin. On the basis of that, they predicted a further reduction in risk of about 1/5. And the trial had to be stopped early because they actually saw a significant increase in the risk of death and in the risk of cardiovascular events. And it turned out that this drug was producing off-target effects, so it wasn't just affecting lipids, but it was increasing blood pressure, and it was producing direct effects on the vasculature through the renin-angiotensin system that appeared to be toxic. One interesting observation was in parallel with that clinical outcome study, there were a series of imaging studies conducted. And the idea behind these imaging studies is that maybe this would be a way of doing more efficient trials in smaller numbers of people that would allow you to look at the pathology. So if by lowering LDL cholesterol, increasing HDL cholesterol, you're reducing atherosclerosis in the arteries, then you should see changes in the arteries that you can measure with imaging that would be predictive of improvements in clinical outcomes. And I think that this picture really shows strikingly how that's not the case. Because in this imaging study, and there were 2 or 3 others that show exactly the same result, there was no difference whatsoever between the people who got statin and the people who got statin plus this new drug, torcetrapib. So the imaging did not show benefit, but it didn't show cardiovascular hazard either. Whereas the clinical study showed a clear cardiovascular hazard. I think this is a clear message that these imaging studies are not going to provide a good surrogate for clinical outcomes, clinical cardiovascular outcomes. Another study of one of the other drugs in this class was also stopped early, not for toxicity this time, but for lack of efficacy. So after just a couple of years, with a drug that produced no effect on LDL and is only a very small effect on HDL cholesterol, they stopped it at 2 years. Now, bearing in mind that you may recall from my previous slides that it takes some time for the benefit to emerge. In the first year with LDL-lowering, there's much less effect. 2 years may well have been too short. The fact that there's no effect on LDL also makes this a less than attractive drug. I'll just skip that for time. So there are 2 big trials going on at the moment with the other drugs in this class. Anacetrapib and evacetrapib, this is one of them that we're doing, where we're predicting, again, big effects on LDL and HDL, and by mid-2016, we anticipate from this trial and from the trial of evacetrapib that we will get clear answers as to whether reductions in LDL and increases in HDL really can produce further benefits on top of statin. And then finally, in terms of new agents, there's one of perhaps the most beautiful stories that have come out of the genetic arena. In 2003, a paper was published about a mutation in the PCSK9 gene that was found in a family, and it was found to be associated with a very big difference in lipid levels. They then went on to look for variants in that gene, in the PCSK9 gene, and they found in African Americans a nonsense mutation, so a mutation that meant that the PCSK9 didn't work, that was associated with a very big difference in LDL, about a 1 millimole difference in LDL cholesterol, which would have been maintained over a lifetime. And when they compared non-carriers of this variant with the carriers, they found a massively lower risk of coronary heart disease. So a 90% lower risk of coronary artery disease, albeit based on very small numbers of carriers who developed coronary artery disease, but very strongly predictive that if you have a lifelong difference in LDL cholesterol from these genetic variants, it's associated with it could be associated with a very much bigger reduction in the risk of coronary disease than we see in the trials. People have gone on to look for other variants, and there's a more common variant that isn't a missense variant, but it is associated with not a 1 millimole difference in cholesterol, but with about a 0.4 millimole difference in cholesterol. This was a meta-analysis of the studies that were available at the time. They had much larger numbers, and they were able to find that a 0.4 millimole reduction, lower cholesterol over a lifetime was associated with a 28% lower risk. So again, much bigger than has been observed in the trials with short-term reductions of that magnitude. So 2003, this genetic variant identified. 2013, large clinical trials ongoing of drugs that have been developed to inhibit PCSK9. So PCSK9 binds to LDL receptors. So if you have a lot of PCSK9 in the blood, it binds to the LDL receptors. The LDL receptors get recycled into the liver cell. And if they're bound to PCSK9, they get degraded within the liver cell and instead of being recycled to the cell membrane. So you have fewer LDL receptors, and therefore the LDL cholesterol level in your blood goes up. So if you can inhibit the PCSK9, you allow more of the LDL receptors to recycle, and therefore they're available to pull LDL cholesterol out of the blood. And so, as I say, this genetic target identified in 2003, by 2013, a number of companies, Amgen, Sanofi, had developed subcutaneous injections that could be given every few weeks that would inhibit PCSK9 and lower LDL cholesterol. And so this is placebo. This is giving it every 4 weeks. And then the smooth curves are what happens if you give it every 2 weeks. And we're talking here about a 60 to 70% further reduction in LDL cholesterol on top of a statin, or indeed in the absence of a statin. So there are now large clinical outcome studies going on with these agents, not given as a tablet, but given as an injection, because they're an antibody, that are being done to see whether we can get further reductions in the risk of coronary artery disease. So my conclusion would be each 1 millimole lower LDL cholesterol reduces the annual risk of major vascular events by about 1/5. But actually it's a bit bigger than that, because after the first year it's about 1/4, year on year. That we've now demonstrated larger LDL cholesterol reductions safely produce definitely larger reductions in the incidence of heart attacks, revascularisations, and ischemic strokes. I didn't show this, but there are similar proportional reductions in all of the different subgroups that we studied, male and female, young and old. I did show people at higher and lower risk, and also the SHARP study shows similar benefits in renal disease. There doesn't appear to be any threshold, at least within the RAISE study, below which lowering LDL cholesterol isn't associated with lowering risk. So we really should be looking to lower our LDL cholesterol in people who are at high enough risk to want to do it by 2 to 3 millimoles, by combination therapy, lowering risk by 40 to 50% with this single intervention. And as yet, the benefits of raising HDL cholesterol on top of that remain to be demonstrated. Thank you very much.
Questions, anyone?
Sorry, I went on a long time, so you
I
may
have a
be
brief one.
exhausted.
Yeah.
This might be an ignorant question, but just thinking about the
PCSK9.
Yeah, thank you. Is it possible for us to manufacture some sort of fluorochrome to track LDL?
Some kind of
Fluorochrome to track LDL receptor expression, which would give us an idea about risk, not necessarily.
about risks of what?
Yeah, of cholesterol. Because as you were saying at the introduction of your lecture, you mentioned that it's not necessarily about, oh, I have high cholesterol, can you lower this? Or I have high blood pressure, can you lower this? It's about risk.
Yeah.
Right. So is it feasible to say, if we were to track LDL receptor expression on the cell surface?
Would that tell us about risk?
Yes.
I think the main determinants of risk are things that are quite, in general, quite easy to measure. Age is the first one. Previous history. So people who've had a heart attack or stroke already, people who've got other risk factors beyond cholesterol. So the combination of risk factors is your cholesterol high, and do you have a high blood pressure? Do you smoke? Are you overweight? Do you have diabetes? Most of the factors that determine your risk are easily measured things. There has been a lot of discussion about using genetic information to predict risk. What's really emerged from the evidence is that most of the genetic variants that we measure have only modest effects on the risk of disease. So actually predicting risk by adding genetic information into these risk scores does not look likely to be very helpful. Partly because they only have modest effects, but largely because they appear to have their effects through the things we already measure. So most of the genetic variants that are associated with the risk of coronary disease are associated with the risk